Welcome, everybody. This is the another webinar by the nuclear chapter of the SAIEE, and it's on radiation medicine, nuclear medicine and radiation biology. We have three extremely good panelists. We have Professor Vangu from Wits University. We have Ms. Tshetlhane, who is the managing director of AEC-Amersham, which is one of the major, which is a South African state producer of radiopharmaceuticals. And we have Professor Avery from the University of Pennsylvania, and I'll give him full sympathy because in Pennsylvania it's now 4 o'clock in the morning. So his comment was that he doesn't normally get up this time, so he has my complete sympathy. Just some words of how we're going to do this thing. Please, attendees are reminded to ensure the volume is turned up on your device. Ensure you have a stable internet connection, and that will ensure that the streaming and audio run smoothly. The attendees can ask questions via the questions panels. On your screen there is a little thing called questions. Please open that up, and if you have any questions, put them in there. We will handle the questions at the end of the 3 presentations when we've heard all the presentations. The chat function is only available for the organizers and panelists, so I'm afraid that's not something you're going to get into. A recording of this webinar was made available on the SAIEE YouTube channel, SAIEE TV, under if you look at the list, you'll see it under the nuclear chapter area. It's updated regularly, so please check back as often as possible for new uploads. And please click on the link that will appear in the chat box shortly to subscribe to the SAIEE TV channel. It's free. Well, it's sort of free. We just trying to very much. And for those who are wishing to get CPD validation certificates and attendance, a certificate of attendance will be issued a few weeks after the webinar once you've received the CPD validation number from EXA. So that there should be CPD credits to go with this application. So that's the opening statement. Now, just to introduce who am I, and I'll start with myself very quickly. I'm non-executive chairman of NEXA and also the chair of the SAIEE Nuclear Chapter. I was the chief nuclear officer at ESCOM until December 18, when I retired at the ripe old age of 65. And I'm also a the chairman of the technical working group on nuclear power plant operations and other things. So I'm not going to go any further with that because I'm not the important person today. It's the presenters that are important. The first presenter is going to be Professor Vangu. He's a chief specialist and head of nuclear medicine at Wits. He's a chief specialist, professor, and head of nuclear medicine at Wits for the Johannesburg Academic and Baragwanath Academic Hospitals. He's also the head of the Department of Radiation Science, University of Witwatersrand. His academic qualifications as follows: MD, MM.Med, MSc, PhD, and has numerous publications, conferences, and workshop proceedings, as well as keynote addresses locally and internationally. He also received a certificate on his executive MBA from the University of Nebraska, USA, certificate of fundamental clinical and translational research with Harvard Catalyst Educational Program, Harvard, USA. So I will now pass you across to ask Professor Vangu to make his presentation. There we are. Yep. So we now should be going to Professor Vangu.
Thanks, David, for the kind introduction, and hello, everybody. I'm going just to take you now into this presentation. I want first to thank Nuclear Chapter for organizing this continuing educational event. And today, as you know, we're going to try to tell you some benefits of nuclear technology in healthcare. So well know that nuclear technology usually you use them to meet some of the benefits and the needs in the modern life, mainly energy, proper medical care, food production, water resources, and so on. So allow me actually to take you back to about 7 decades ago, when at the UN General Assembly, President Dwight Eisenhower said that the responsibility of the Atomic Energy Agency would be to provide means so that fissional material can serve for peaceful pursuit of mankind, in particular agriculture, medicine, and supply of electricity. So today, the International Atomic Energy Agency, the IAEA, look at all these applications as the benefits of the atom for life. And as part of the nuclear chapter, us as the group of medical session, we're going today to give you some of these benefits of nuclear technology in healthcare. So I'll be the first presenter, and then what I'm going to do, I'll try to show you some of the many options of treatment that exist in nuclear medicine. But before I start it, I want to give you the information that I think is important. Although I work closely with professionals from all these three specific and well-specialized entity in radiation medicine, I am a specialist in imaging and therapy in the field of nuclear medicine, and I'm not claiming to be something I'm not. So in the next 20 minutes or so, what I'm going to do, I'll give you quickly a background of what is available in terms of the agent that you can use in nuclear medicine for therapy before I define the targeted therapy per se. And then I'm going to go to the notion of peptide receptor radionuclide therapy, which is known with the acronym of PRT that you use in patients with neuroendocrine tumor. And then similarly, in using the same concept, today we start using also in patients with prostate cancer, what you call radioligand therapy, and some other people that call it the PSMA radionuclide molecular therapy. And then I'm going to close with 2 slides. And in these 2 slides, I'm going to summarize my presentation and give you my view for the future. Let's start. The use of radionuclide or radioisotope for treatment is not a newcomer if you look in the class of all existing therapy that are out there. In fact, one can trace its use far back from the early late century during the first isolation of radium by Marie and Pierre Curie. But in practical life, in practical medicine, it is only with the production of phosphorus 32 that actually radionuclide therapy took off. And simply because P32 was found to be very effective, very, very effective in the treatment of polycythemia rubra vera, which is a bone marrow disease where you have an overproduction or excess production of red blood cell. More close to the usual practical nuclear medicine, you will see that radioactive iodine has been the very first form of target therapy and well accepted. And it's used in patients that they have overworking thyroid gland, and mainly, and its impact is mainly in patients that are suffering from thyroid cancer. So radioactive iodine was introduced for the first time in 1940 one by this gentleman that you see a picture there, Saul Hertz. And then in patients with thyroid cancer, it was used for the first time in 1943 in a patient at the Memorial Hospital in New York. And then 3 decades later, most of the publication and the report starts emerging and coming to show the benefit of radioactive iodine in a patient treated with thyroid cancer. So images like that, they speak loudly. You don't need even to see an explanation. And then that's why today you can see physicians are really in love with the use of radioactive iodine for treating patients with thyroid cancer. So other forms of treatment in nuclear medicine will include, not exhaustively, but this list I put there. You can label together iodine 131 or yttrium 90 with monoclonal antibodies for the treatment of follicular lymphoma in patients who fail treatment with the routine medical therapy. And iodine 131 can also be linked or labeled together with MIBG, and then it's been used for many years, over 40 years, for patients that are suffering from pheochromocytoma, neuroblastoma, or medullary thyroid carcinoma. And then for patients that they have the cancer spread into their bones, and then they are symptomatic, and for quite 5 decades now, the pain can be controlled by isotope like strontium-89, samarium-153, or rhenium-86. But a decade ago, a newcomer joined the team, which is a alpha emitter, radium-223 dichloride. It used it in a big trial that showed the benefits and the success of using this form of treatment in patients with prostate cancer and spread into the bones throughout the body. And this is one of the key elements of targeted therapy today in prostate cancer. So when does the modality be called target therapy in a nuclear medicine? So the simplistic way of defining that will be that you have radiopharmaceutical that will be delivering some doses of ionizing radiation in specific site of disease. So broadly, you can keep it in mind that will be look at it as the use of radionuclide that transported by some vehicle that we call molecular vector, biological. It's simply brought the notion that PRRT. So PRRT is actually the revolution of targeted therapy in nuclear. Is explained simply the fact that most cancer, they express some receptor in the surface of the tumor. And then in neuroendocrine tumors, action of somatostatin receptor that can be coupled with radioactive radioisotope, so that you can a way of treating. It's called a very asthma. So to overcome that, synthetic somatostatin analog has been developed, and then you hook them with radioisotope. Then you can treat the patients with neuroendocrine tumor. So this cartoon actually simplify this PRT by saying that you have a radioisotope that could be an yttrium-90 or a lutetium-177, and then this radioisotope is linked to a chelator or a carrier that usually we use some chelator that is a macrocyclic. Here we use a daughter, and then this daughter then will be coupled with a somatostatin analog, depending of the chemical structure of the somatostatin analog. You may have something like a tyrosine octreotide, that is a TOC, or you can have a naphthalene octreotide is a NOC, and so on and so forth. So this is actually a simple principle of using PRRT in clinical practice. But how do we use it, and then who should benefit from it? Practically, you use it in patients that having or suffering from neuroendocrine tumor, but this tumor must be expressing somatostatin receptor. How do we know it? We know it through imaging, and I will show you image later to show that this is the expression of somatostatin receptor. And then this patient, usually they have disease that is spread throughout the body. Sometimes they can have disease that are confined in one part of the body, but because of some reasons, such as being close to major vessels, then operation is not possible. These are the patients that will benefit from this kind of treatment. And then one of the caution is that when you do histology in these patients, they must have a well-differentiated neuroendocrine tumor, which usually, according to WHO, will be a grade 1 or 2. Because patients with grade 3, they will not respond to this treatment. And then in the right-hand side, you have the common diseases that we put as part of this neuroendocrine tumor. So what do you give to the patient? You give what you have available on hand. You may use yttrium or you may use lutetium. As I say, it could be a DOTA-TET or DOTA-TOC. In South Africa, we have only lutetium-177 available. And the second speaker in this meeting is well situated to tell us why we are not the yttrium available if needed to be so. And then when you look at these two, left and right, you compare, you'll see one difference. The yttrium, because of its long range of beta radiation, the number of cycles of treatment is less than lutetium. Similarly, also the dose is lower than lutetium. Why is it so? Because you want to prevent targeting the bone marrow, that will be the limiting factor, or even the kidney, so that you can have toxicity because of this long range of yttrium as compared to lutetium. But either of them, yttrium or lutetium, sometimes in very limited number of patients, can be used in combination with chemotherapy in a concept that is today known as a PRRCT, so peptide receptor radionuclide chemotherapy. And looking at the outcome of this treatment, to date, there is a phase 3 trial that was done and to look at the efficacy of PRRT. And I'm not going to go into many details there, but that trial that was called the Neuroendocrine Tumor Therapy 1 or NETA-1, you can Google it as a NETA-1. The main information that you can see the Kaplan-Meier curve into your left, or the A, progression-free survival, it tells you patients treated with lutetium DOTA-TET have had a longer period of free disease compared to the one that were treated medically. And then in the right-hand side, or the B1, if you look at the Kaplan-Meier curves there, you will see that patients treated with lutetium die often less than those treated with the standard care. Now, I just show you this image to explain what we call expression of somatostatin receptor. So before you do the treatment, as a prerequisite that I put there, the patient should show expression of the somatostatin receptor. We give a patient something similar to what we're going to give with the treatment. The difference is, rather than giving that lutetium, which is the hammer that you give for treatment because of the beta radiation, you give them a gallium-68, which will just emit high flux of 150 kV of gamma, so that you can image. And you can see our patient here having a disease that is spread throughout. So this one, anybody can see it. All the dots that you're seeing there is the disease is there. And then the second image that I'm showing you here is to look at the efficacy of the treatment. This is one of my patients that's a 67-year-old, presented with pancreatic cancer and metastasis in the liver. As you can see in the image in your right, after receiving 4 cycles, in the middle of the abdomen, you can see that the disease in the pancreas and the abdominal nodes are gone. And the lesion that we had before we started the treatment, we counted them, there were 58 lesions. And after 4 cycles, there were only 11 lesions. So this was a good partial response, and patient are doing well. Then we decided to give further cycles so that we can actually complete this treatment. The beauty of lutetium is that on one side, it delivers beta radiation so that you can knock down the disease, you can really kill the disease. But at the same time, it also emits some photo that will be able to image the patient, as you can see the 2 images on top there. And then we image the patient serially so that we can do dosimetry, which is a prerequisite to know how much of the radiation given to the patient actually went to the cancer and how much went to the normal tissue or to the bone marrow. And then you know that the toxicity to the bone marrow is a limiting factor, as patient may bleed or may easily. So this is the beauty of having lutetium, because you can do dosimetry. So similarly, as I said, that the concept of the success of the PRRT, then the concept has been moved towards prostate cancer, and to use almost the same concept that I explained to you, but linking PSMA, which is similar to the receptor that you have in prostate cancer. That's why prostate cancer, those of you know, when you go for testing in the lab, they do a PSA, but now you have a membrane, so PSMA, so that we can link it to lutetium. And the first phase 3 study was published last year in June, in what is known today as a buzzword in prostate cancer everywhere in the world, the VISION trial. So I want just to go back a bit and explain, because I said it first in the PRRT, the phase 3 NETA study, and now phase 3 in VISION. For those who are not in the medical field, I just want to define what is phase 3 means. So anytime that a new drug is produced, before you take it to the market, you first use it in a smaller number of volunteers and to test the toxicity. We call it phase 1 clinical trial. And if it's not toxic, and then we're happy with it, then you can now try to test it in a smaller group of patients, so that you can start now optimizing the dose to know how much you should give. And it is called phase 2 clinical trial. And then if we are happy with the dosage, we're happy with the toxicity, then you can give it now to a larger number of patients that can be from different sectors or even from different countries. This is what you call a phase 3 clinical trial. So the phase 3 clinical trial of this lutetium PSMA or the radiation ligand therapy, I'm going just to give one slide to tell you the summary. If you compare the 2 curves there, you can see that patients that were treated or received this lutetium PSMA, they live longer compared to the one that were treated with the standard of care. Now, look at this image, one of our patients, 72-year-old. In the 2 images in your left-hand side, this is at the diagnosis. A patient with prostate cancer, you can see the disease is spread almost from head to toe. You can see from the skull everywhere, all the hotspots there you're seeing is cancer spread. And only after 2 cycles, we didn't even finish 4 cycles yet, you can see already that most of the disease is already gone, and telling us that this patient will respond when we finish the 4th cycle. And we give the patient treatment each cycle is given every 3 months. And this is a 71-year-old male that presented with prostate cancer that spread in the lungs. Look at the chest in the image on your left. All these spots you're seeing in the chest there are lung metastasis. And then look, when we finish 4th cycle, the 2 last images in your right-hand side, you see completely clear. So patient had a complete response, and all these metastases, they become quiet. So to summarize and remain in time, I hope that the few information that I gave you here, I try myself to be really in a layman language, not to be in the medical terminology deeply. I hope that something. And then in what I said to you here, I managed to show you that radioactive iodine, or the other 2 targeted therapy known as the PRRT for neuroendocrine tumor, and the radioligand therapy in the prostate today, are giving very good outcomes. So my opinion is that this line of therapy will only continue to become popular as we move with time. But we have to keep one thing in mind. Each patient should be looked at individually and differently, and so that we'll be able to tailor the treatment according to a particular individual, because we should not use a one-shoe-fits-all philosophy for this kind of patient. So I stop here, and I thank you for listening to me.
Thank you very much, Professor Vangu. I think that's very interesting. The last few slides, I'm not an engineer. I'm an engineer, not a doctor, but the last few slides fascinate me, because that looks like a solution to the classical late-stage cancer, to my simple thing. We're next going to go across to Mapula Tshetlhane. She's a pharmacist and is currently the general manager of ESCOM. That shows my age. Sorry, 34 years in ESCOM. It's the company AEC-Amersham, which is a subsidiary of Nexa, or subsidiary of NTP, which is subsidiary of Nexa, which produces the radioisotopes. And she's basically holding that position. So I will now pass the screen across to her and ask the other question of the previous presentation was, how do we use this lot? And I think she's going to present to us how actually we make this lot and how it comes out unit. So I'll pass across to Mapula. Mapula, the floor is yours.
Thank you, Prof. Nichols. The intent of my presentation really is to share with the audience how we use nuclear technology for peaceful purposes at Pelindaba near Hartbeespoort. The Safari 1 reactor is 20 megawatt. Sorry. Tank in pool. Can you see my presentation? Because on my side it disappeared.
Yes. No, it's fine from here. We can see it.
I just need to find my presentation on my side. Oh, okay. The Safari 1 reactor is a 20 megawatt tank in pool type nuclear research reactor. It is owned and operated by Nexa, located at Pelindaba, which is 30 kilometers west of Pretoria. The Safari 1 reactor was commissioned in 1965, and it is still currently the best performing research reactor in the world, running for more than 300 days per annum. This reactor is fully converted to LU fuel, and this took place in 2009, and it is the first commercial reactor that successfully converted to LEU fuel. The LEU targets that are used to produce molybdenum-99, the targets that are used to produce molybdenum-99 are also LEU based. The Safari 1 reactor has an exemplary safety and supply record since 1990. To share with you a unique arrangement of facilities at Pelindaba. We have the Safari 1 reactor just less than a kilometer away from the API radiochemical production plant and also away from the radiopharmaceutical plant. This is a very unique arrangement of facilities because it is not common in the European competitors of NTP. You will find that the reactor is not close to the production plant. They are not on the same site, and therefore target plates need to travel on public roads. That has an impact on the flexibility of production, and therefore this makes NTP a much flexible producing company. They can produce January to December without too many public road regulations. Just by the way, not a nuclear medicine related matter, but just for interest's sake, the Safari 1 reactor is also used for silicon transmutation doping. The transmutated silicon is very important for the electronic industry because it is used to manufacture microchips that are used in gadgets such as laptops and cell phones and etc. Also, just for your interest, this plate here on my right, the small picture at the bottom, the plate that you see there, that's a molybdenum-99 target plate, which will be placed in that target plate holder and sent into the reactor. And therefore, what we are talking about when we talk of LEU target plates for molybdenum, it's not much longer than your ordinary pen. Also, another interesting point about Pelindaba is that the Nexa group has the capability to design, manufacture, and license various transport containers. The picture at the bottom is a molybdenum-99 transport container. It weighs 125 kilograms because there is depleted uranium in that container, and that the purpose of that is for shielding. It can take up to 1,500 curies. This product, molybdenum-99, doesn't fly on cargo flights. It flies on passenger flights, and therefore, just for your interest, it might be in your passenger flight as you're flying to the US and across the world. Now, to the story about the radioisotopes that are produced at Pelindaba. We have two ways of producing radioisotopes. We can activate a target as we can have diagnostic radiopharmaceuticals, and we can also have therapeutic radiopharmaceuticals. Vangu emphasized more on the therapeutic side, and he spoke about Lutetium-177, but let me take you through. So when we talk about diagnostic radiopharmaceuticals, we've got molybdenum-99. Molybdenum-99 is an active pharmaceutical ingredient. It is not the final product that will be injected into the patient's body. It is used as a component of molybdenum-99 technetium-99M generator. Molybdenum-99 has got a half-life of 66 hours and can be easily exportable across the world. NTP is amongst the top 4 producers of molybdenum-99 in the world. Why is this product important? More than 75% of all nuclear medicine procedures use technetium-99M, which is a daughter nuclide coming from molybdenum-99. Over 40 million nuclear medicine procedures, diagnostic procedures, are performed worldwide annually using technetium-99. 8 million to 10 million of those will be produced by NTP. So just to help you understand a little bit about the generator system, the molybdenum-99 technetium-99 generator system, it is also referred to in layman's terms as a molecule. So just think of at the farm, the farmer will milk the cow every morning to get the milk. It is the same principle that applies when it comes to the generator system, because in the medical center, they will milk the generator every morning to get their technetium. The 6-hour half-life and 147 kV energy of the technetium-99 makes it ideal for nuclear medicine investigations. The half-life is just short enough, and the energy is also just enough to do the nuclear medicine procedures. The parent molybdenum-99 is adsorbed onto an alumina column, and which acts as the ion exchanger. Then the molybdenum-99 will decay by beta and gamma emission to form technetium-99M. Then when normal, during elution, during the milking in the morning, during the milking process in the morning, normal saline will be passed through the column and it will collect technetium-99M, and this forms sodium pertechnetate. Then again, not to confuse it, but the sodium pertechnetate is not used alone in many procedures. Many procedures will have technetium-99M labeled or tagged with another pharmaceutical agent. And the pharmaceutical agent is the one that will direct the product to the specific area or system of the human body. Then the labeled product will be used in medical imaging to assess how particular parts of the body are working and functioning. Just one example of the labeling kits that we manufacture at Pelindaba, and it is also the most used labeling kit. It is called MDP. So once you have a technetium-99 MDP product, it is used for bone scanning, mostly for visualization of tumor metastasis in bone, for osteomyelitis, for fractures, and for osteoporosis. The second radiopharmaceutical that we manufacture that is used for diagnosis is called fluorine 18 or F18 fluorodeoxyglucose. So when it comes to cyclotrons, we've got 2 cyclotrons. One cyclotron is based at Pelindaba. The second cyclotron is based in in Fore, which is in Cape Town, under the operations of Itemba Labs. And these 2 cyclotrons are dedicated towards the production of F18. So of F18 as the isotope. The final product called, in simple terms, we just call it FDG. We've started producing this product since 2005. It is registered with SAPRA and the brand name is TrueScan. Now, interestingly, the half-life of the fluorine 18 is only 109.8 minutes. That's very short. That's just less than 2 hours. With this short half-life, we have to produce every single day because we can't store this product on the shelves. By the end of the day, the product is finished. So we have to produce every day, Monday to Friday. We can't even export this product. The radiolabeled glucose, which is FDG, is the main product used for PET-CT investigations in clinical oncology. It is used for staging and restaging of cancers. It can be used for pre-surgical planning, for evaluating disease response to chemotherapy and radiotherapy. It can also be used to differentiate benign lesions from malignant lesions. The third radiopharmaceutical that we produce is called F18 PSMA. Because of the fluorine 18, talking of a half-life of minutes, again, we can't export it. But this product is much newer and it is not yet registered with SAPRA, and therefore we are currently producing once a week. Therapeutic purposes. Iodine 131 has got a half-life of 8 days. So in terms of the iodine capsules, we manufacture and supply throughout the continent. But in terms of the iodine 131 API, which is the active pharmaceutical ingredient, NTP can export it worldwide. It is indicated for imaging and therapy of thyroid carcinomas. Now, the more exciting products that Prof. Vangu also talked about, the future of nuclear medicine. We manufacture Lutetium-177 NCA, the API in the API format, which is the active pharmaceutical ingredient. NCA stands for non-carrier added. We also manufacture Lutetium-177 dotatate, which is a pharmaceutical, and then we also manufacture Lutetium-177 PSMA, which is also a pharmaceutical. Just to take you through the rationale why NTP chose the NCA route, there is a very important reason why NTP chose the NCA route. So NTP chose to adopt the Lutetium-177 indirect route, and NTP partnered with a company called ITM, Medical Isotopes, for the production technology. The product that NTP produces is exactly identical to what ITM produces, and this allows for backup supply, which makes NTP a much more reliable supplier. Now, there are significant advantages why one would go the NCA route. Just 2 reasons. The NCA product has got high radiolabeling yield. It's also got high specific activity even at expiry date. The 2 tables at the bottom, you can see in the red circles, the labeling yield, the table on my left with 98%, that's the NCA. The labeling yield in percentage for the NCA remains at 98% up to day 15 since production. Whereas the CA route, the labeling yield declines every single day and every single week. Eventually it goes down to 9.8%. That's not good for the volume that you need to inject into the patient would be much smaller in the NCA product than the CA product. But the most important reason, which is a takeaway point for all of us, is that the Lutetium-177 NCA doesn't have the long-lived impurity called Lutetium-177 metastable. Whereas the Lutetium carrier added has got this impurity called Lutetium-177 metastable. The biggest disadvantage with this impurity is that it's got a half-life of 160 days. At the medical center now, not at NTP level, but at the medical center, after they've injected the patient, all the remaining syringes, vials, everything needs to be stored for at least 2 days. And the urine from the patient needs to be stored for at least 2 days to allow this Lutetium-177 metastable to decay. That will definitely clog the healthcare system. But I can assure you that NTP and Nexa are very responsible because they chose the environmental friendly option. In terms of manufacturing of this new technology, the target Ytterbium-176 will undergo 10 to 14 days of irradiation at the Safari 1 reactor. So we are using our own reactor again for this product. This product is produced in a current GMP, current good manufacturing practices compliant facility. So CGMP stands for current good manufacturing practices. So this facility is compliant. It meets SAPRA requirements, even though the product is not yet registered, but the facility is registered. NTP invested more than 55 million rands into this facility. Purification and separation takes place in the facility. The Lutetium-177 NCA will be terminally sterilized via autoclave. Quality control testing also is performed and must meet all the specifications as per the European pharmacopoeia. So on my right, the picture at the top, that's the hot cell infrastructure for production of this product. And you know, when we are talking about our products, sometimes people think we're talking of something big. We're talking of big things, but the product will be placed in small vials like that. I think that's a 5 ml. We can use 5 ml vials and 10 ml vials, and that will be the lead pot for shielding purposes. So we're not talking of a drum. We're not talking of a 20-liter drum. We're talking of 5 ml, 10 ml. In the case of molybdenum-99, I think they can go up to even 20 mils vials. Those are the volumes we're talking about, but the radioactivity content will be strong enough for production of pharmaceuticals. Then still on this lutetium-177 AP, the API, just again to help everybody understand, when we're talking of an API, it is a radiopharmaceutical precursor. It won't be injected as it is into the patient. It still needs to be tagged to a pharmaceutical agent and the carrier, as Professor Vangu was explaining to us, in the process called radiolabeling. Once it's radiolabeled, then it can be injected. So the carriers, the agents that are used in the case of lutetium, it can be peptides or antibodies, which will direct the lutetium chloride to the disease site in the human body. Lutetium-177 NCA is made available as a sterile product. It is calibrated for up to 7 days from the date of dispensing. It's got a shelf life of 9 days from the date of dispensing. So that's significant. That's long enough to export this product. When we're talking of lutetium-177 dotatate, it is indicated for the treatment of metastatic pancreatic neuroendocrine tumors. This product, this pharmaceutical product, has got a shelf life of 3 days. So we only, once it's from the date of labeling to the expiry, we've got 3 days. So for customers that are far from Pelindaba and we can't deliver this final product, we can easily supply them with the lutetium-177 API, as well as the peptide called dotatate, and they will do the radiolabeling at their site. That makes it much easier. But for areas that are within reach, we can easily ship this product. We can easily do we can actually easily do the whole of South Africa. We can do Cape Town as well. Then lutetium-177 PSMA, which is a pharmaceutical. It is indicated for the treatment of metastatic castrate-resistant prostate cancer. This one, unfortunately, at the moment has got a shelf life of 3 days. More work has been done to extend that shelf life, but at the moment we can at least ship it around Gauteng, and we can also we easily do Durban. We have done Durban quite a number of times. Interesting enough, we've actually also done neighboring countries such as Zambia. But there we are also dependent on the flights, that they are on time, and even the local transport once it arrives in Zambia, that everybody will react and treat it as an agent product. But for areas where we can reach them with the labeled product with a shelf life of 12 hours, we can easily deliver the lutetium-177 and API, as well as the peptide called PSMA for labeling at their site. I thank you, Prof. Nikos. Thank you, Prof. Vangu. But just to emphasize, nuclear medicine is safe, and you can in future recommend to your GP that maybe I should try nuclear medicine. Thank you so much.
Thank you, Mapula. I think that's excellent presentation. I will have to declare conflict of interest because clearly, as chairman of Nexo, I'm very supportive. What is interesting to note from that presentation, and AEC-Amersham mainly covers the domestic market around here, is when the airlines shut down under COVID, it shut down this industry because you've got to get things overseas. Molly-99 has to get there by direct flight, so thought process. Okay, having had a couple of South African views of the world, we now go to the early morning riser, Prof. Steve Avery. He's an associate professor of radiation oncology and is certified. Oh, I lost track of my thing. certified to therapeutic physics by the American Board of Radiology. He's currently the chair of the Global Medical Physics Education and Training Committee for International Council of American Association of Physicists in Medicine, and a member of the African Organization for Research and Training in Cancer. He's actively collaborating to establish a cancer research training program in Tanzania and other areas in sub-Saharan Africa. With funding from the National Cancer Institute of NHI, he's hosted the Global Health Catalyst Summit of GHC. So with that, I'm extremely happy to hand over to Professor Avery. The floor is yours, Professor Avery.
Okay, thank you. Thank you for the invitation to this webinar. I don't mind the early hours. I think as scientists, we have varying hours of work and times when ideas pop in our head. So, so for the talk today, I just want to focus on medical physics in general. I think there are people who may not quite understand what it is, what we do, and it has some ties with the former speakers also on exactly why it's important and some of the background that's needed in medical physics. So what is it? You know, medical physics is a very interdisciplinary field. It consists of, you know, therapeutic medical physics. I think this is probably the area that people most think about when they think about medical physics or radiation oncology. Also, diagnostic and imaging is a big part of it. But there's also modeling, optimization. There's data analytics, decision making. AI is really taking off in this field because they see that the value of it. So medical physics in itself, or radiotherapy, has been an evolving field for some time. And I think that you know, we're moving in an area now where probably 40 years ago, people did not envision medical physics being what it is now. So I think it's really an idea for this group, and seeing that, you know, the things that you're doing actually has some application and need in the area of medical physics. So first, I did want to mention a little bit about the African strategy of fundamental and applied physics. This is something that is ongoing now, and something that is really consists of a multiple number of working groups, one being medical physics. But as you can see, there's different disciplines: nuclear physics, particle optics, because like I mentioned earlier in the early slides, that this is interdisciplinary field, and so I think engagement with other disciplines and other areas is really crucial and vital, and also to bring in a lot of the younger students and younger scientists who may not know about this field but have interest in applying their skills into the medical area. So basically, what is this fundamental strategy? It just says that, you know, Africa's, you know, should be in the forefront, a co-leader in the global scientific process, and take advantage of all the socioeconomic benefits that there is. And I think that this is one of the things that, you know, we are looking at, and that we want to really develop and establish, that to develop a strategy to say these are things that are needed, and to bring all these different groups together as we're doing today. So it's in the process now, and the goal is, although COVID has slowed things down, as it has everything in the world, but the goal is that a report which would be given to leaders and policymakers to say that, okay, this is what's needed to really take, you know, things to the next step, and really establish, you know, Africa as far as the science and technology leader. So a little bit about myself, my career in medical physics. How did I get here? So I think I started out as a nuclear physicist. My degree was from Hampton University. I worked in Argonne National Lab and Jefferson Lab. I didn't think about doing medical physics at all. I thought about being a high energy particle physicist, looking for the Higgs boson and doing those kind of things. But then University of Pennsylvania opened up a proton center, and I thought that was kind of interesting, and so became an instructor then assistant professor, working in the clinic. We're board certified just like the physicians, and so that was one process that's different from like being a basic scientist or engineer. And then became associate professor. But I think what's nice about the background that I had is that, and with medical physics, is that you bring those skills into medical physics and can apply it, because one of the areas of research that I do is thermoacoustics, as well as global health and medical physics. And that comes a little bit from my background in nuclear physics, where I was able to bring that into the field. And so just quickly, conceptually, what is it? I could call it protoacoustics because because we're looking at protons that would generate this sound. But basically, when we treat patients with protons, it actually generates heat. It creates very rapidly, the temperature goes up. All this is a small scale. This is microkelvins, and it's about 0 to 40 microkelvins that the temperature would increase, but over a very rapid time period. And during that time, it creates this, say, sonic boom or a pressure wave. And that pressure wave is actually, it's proportional to the heating function, proportional to the amount of energy that's delivered through this Greenesian parameter, which is the expansion coefficient times the speed of sound over the heat capacity. And so what actually happens is that when a proton stops, it emits this acoustic wave, and then you get this two pulses. You get a cooling and heating and rapidly cooling pulses. And so with that, since we know actually the time that the proton came in, and we can measure the time of the first pulse, we can do a time of flight. And again, this came from my background in nuclear physics that I can apply to medical physics as an application. And I think this is one of the things that I hope this group can think about also, is that some of the things that you're doing now or interests you may have can have application into what we're doing. So what is it that we do, and what is it that we want to focus on? So radiation physics is the science of ionizing radiation interaction with matter, special interest in energy absorbed. So we're clinician scientists, and like I said earlier, it's either diagnostic or therapeutic physics that you think about, when you think about us. But it's a range of areas. We look at the production of ionizing radiation. Again, the earlier speakers discussed some of the other applications. Detection and measurement of ionizing radiation is very important. And I just gave an example of one area that I'm interested in, which is a new way of detecting, but there are always different ideas that are needed as the technology increases and the problems become more difficult. Development of optimization, quality control, radiation safety and shielding. And so again, it's a broad range of areas when you think about radiation physics and what a job of a medical physicist should be. So when we think about treating cancer with radiation, I think one thing that we need to understand is that half of all cancer patients receive radiation therapy. Although there are different modalities that are used also, is therapy and chemotherapy, but 50% of them will receive some form of radiation therapy. And so I think before COVID took center stage, cancer was really the pandemic that we were looking at as an issue that is going to be a real problem, especially in the African continent, in the next 10 to 15 years, because not only is the resources needed as far as manpower, but also the technology too is needed in order to keep pace with the amount of patients and the amount of need that we see coming in the next 10 to 20 years. So generally there are two goals. We want to destroy the tumor, we want to spare the normal tissue. And so that's kind of the challenge that we have. And this is usually a balancing act of, okay, what is the best plan to moving forward in order to have the best quality of life? And so, plans are designed so that we can collimate and direct the beams into a certain area, and trying to avoid the organs at risk or the critical structures. And this is a challenge, and I think that this is a challenge where now that with different types of ways to deliver the beam, and also with all the issues that come with it as far as motion and changes day to day, I think there are definitely needs. There are needs that we need to look at in order to address these challenges. There are multiple ways to deliver radiation therapy. At the top is this is a proton center. You can there's also carbon centers. So I know in South Africa there are heavy ion facilities here also. You can have external beam, photons or electrons. You can have also radioisotope therapy, and then we've heard of, again, the previous speakers talked about different types of isotope therapy. This one here is just a brachytherapy type treatment where you either use cobalt or radium-192 or sometimes iodine in order to place the source at the location. And so even with these different types of areas, that they have their challenges. One challenge, particularly with, let's say, heavy ions, is that it's true that they deliver a lot of energy, but they stop in the body where the photons continue to go through. So if you have this very energetic particle that's stopping somewhere in the body, you really want to know where it stops and where it's delivering its energy. And so again, that's just one of the many challenges. So the workflow consists of a team, which is the oncologist, the physician, the medical physicist, the dosimetrist, which is a person that does calculations on different types of plans. You have a technologist. That person works with the patient directly, sets them up, gets them ready for treatment, and then the nurse would be more of a follow-up. But all of this workflow is also complemented by engineers, computer scientists, mathematicians, information technology experts, with the goal, again, of trying to cure the cancer and spare the normal tissue. And so, again, it's not just the oncologist, but this is a whole team of people and ideas of how to continually improve how we deliver radiation. The plan usually starts with a CT simulation, because we do the planning in 3D space, and also the CT gives us an idea of where things are located, because a CT, you can see all the bony anatomy, and so you can look at where in the body you're trying to treat. And so also for the CT simulation, it simulates what will happen in the patient room. And so you can see here in the top right, you have a person laying in the same position that they would be treated with radiation. And also in the bottom right too, you can see, like, so they will actually be imaged in the way they're treated, and we will plan and do the calculation in that way, because the patient would be treated every day the same way. And so you want to make sure you minimize any error of how they set up, or you're sure of what's needed as far as the immobilization devices that will come with the plan. And so once you have the image, then the physician can start to contour different areas. So he or she may say, okay, I want to treat area 6, but area 7 and 8, I want to make sure I limit the amount of radiation. And so this is the beginning of, okay, this is my wish list, so to speak. This is what I would like to achieve in order to give the patient the best possible outcome. So then once that plan is, or once that, I guess, idea is described by the physician, then there's a calculation done, and we can do actually the treatment planning. And here you can see, like, this is the result of a plan. So the dark red is where it's the highest part of the radiation, and blue is the lowest. And so and there's different ways of also doing the planning too, where you may say that, okay, I want to limit the amount of dose I give in one area. and actually increase the amount in another area. And this is done through a cost function or a dose distribution criteria function here, where this equation shows that where J is your contour planning structure, which we talked about a little bit. D, the dose, is the dose at a point. C is the constraint for a structure. So you can say, I want like this area, maybe like the part of the brain to receive minimum amount of dose. Omega is the is the priority constraint. Epsilon is a flag for meeting that constraint. And so the overall objective is the sum of these objective functions, of the sum of the target plus the organs at risk. And so what you're looking for is something that is acceptable, not optimal. Like, for example, you may have someone who is being treated, let's say, around the eyes, and if this person is a younger person, you may want to make sure you spare their sight. So you may say, okay, I'll give less dose around there just because, you know, we want to have a good quality of life. And so if there is a better way of delivering that, I think like that's where, you know, we lean towards some of our basic scientists and engineers working together with us to come up with, you know, some ideas of how we can, you know, deliver better and safer for patients. We can also do intensity modulated radiation therapy. And here I'm just showing for photons, but this can also be for heavy particles too, where you can actually say, I want to weight one area heavier than the other. So I want to give more radiation, let's say maybe, you know, in the left area here, and then just give a couple of beamlets over there. So this will involve a lot of, you know, computational work, a lot of optimization, computer programming. And so, you know, in order to, and, you know, things have become better and also have improved, but now we're looking at ways of delivering the beam where we can do ultra high dose radiation. So, for example, which I guess the term that's used is called flash. But for a treatment plan that, let's say, may be treated over, let's say, 5 weeks, we can treat the whole plan in a second. And so, and really the benefit of that is that it does less damage to normal tissue and more damage to the tumor site, which again is the optimal goal. But if you're going to deliver that much dose in that short of time, again, you want to first make sure that you know where you're delivering. You know, you can actually do some follow-up. And again, this comes with you know, working with other disciplines and really understanding that how we can monitor and how we can evaluate a treatment, something like that. And so this is not in the clinic now, but it's an idea that people have. And so I think this is where we need to work with scientists from other disciplines. And so here's just an image of, if we wanted to do, this is called arc therapy, where we actually, you can see in the top left where you see the gantry moving around, and you have the multi-leaf collimator moving at the same time, and you're calculating all of these different factors. So again, there are benefits to this, but also we want to make sure that we have the science and the technology in order to deliver and monitor and make sure that the patient is being treated safely. So it's also, we want to be able to reproduce, as I mentioned earlier, it's not that we're just treating once. We may treat from 3 to 42 times. And so if you wanted to reproduce something exactly the same way 42 times, you know, you need some ideas of how am I sure that I'm actually reproducing what I started out at the beginning. So one way that we do that is that we may image the patient with our CT simulation, but then we image them each day. And then we can look at how the patient is aligned. And so basically with the CT, like I mentioned, we can see a lot of the bony anatomy. And so we may look at the vertebral bodies or maybe along the ribs to see, okay, day one, they were set up a certain way. And so let's see if, let's say day two, it's the same way. So here, this is just a comparison between, let's say, the CT simulation and the image from the day that they're treated. And so basically what we want to look for is that, okay, is this patient aligned the exact same way before we deliver the radiation that they were about to deliver. And then there's follow-up also, because it's not just after we have created a plan and make sure that things are working properly. We want to look at along the way, because the patient may gain weight, the patient may lose weight, the tumor may shrink, the tumor may grow. And so there's evaluations that need to be done. And so how do you know when do I intervene? And sometimes that may require doing more scans. But we know that more scans is more radiation also. And so that's another challenge also, is how can we reduce the amount of exposure that we give patients, during our quality assurance. I think that sometimes if you image a patient, if a patient is being treated for 5 weeks and you're imaging that patient, once a week just to evaluate them, at the end of their treatment, you probably have given them another fraction of radiation just from your quality assurance. And so, there's areas of research where we're looking at low dose type imaging, and maybe other techniques that can be used in order to monitor and keep track of the changes of the patient day to day. And so there's a lot of ongoing research that's happening in medical physics, because medical physics is definition here is translational research where basic experimental and theoretical discoveries are rapidly implemented into benefiting humanity through improved procedures and diagnosis and treatment of disease. And so again, it's not just looking at radiation, but looking at different types of areas. One big one is motion. Here you can see, so if you're treating the lung and it's a moving target, how do you know that I'm hitting the target each time? Maybe there's something that we can do or look at. And so with this, we can look at different types of post-processing, where maybe we can color code different areas, or look at the lung and maybe gate it to say that, okay, if we look at the motion, we can turn the beam on at a certain time during the motion. Okay, this requires work from the engineers on how to deliver the beam. Also, maybe there may be some type of processing or other types of technology that can be used in order to help us deliver the treatment more effectively and safely. And so there are a lot of publications out there that can give you an idea of the type of research that we are working on. So one thing I do want to leave you with is that I mentioned AI is an area that is definitely growing, and this is just a slide of the evolution of radiotherapy from the very beginning, where we were just doing X-ray tubes, where today we're looking at linear accelerators integrated with live imaging during treatment and motion and detection, and we're looking at smart learning or decision making, deep learning methods, and so this is a movie of one of my colleagues that just shows that. So he is actually at his desk, and he can look at patients coming into the room, and he can see if they have been set up properly, if they have been treated properly. And so you can see in the red, first the patient can come in, they can check in and make sure, okay, we have the right patient. You can see that the machine is all set up, so when they actually get on the machine, they can see if the patient been set up properly, has a proper dose been delivered. And this comes from working with engineers and different scientists that we can do this kind of work where, especially looking at, some of the issues in coming down the line in the continent also, that, that we can do a lot of the work remotely, or where other people can work together to contribute to the needs of cancer in Africa. So with that, I will stop, and I will give it back to you, Professor Nichols, and I guess we open up for questions.
Okay, thank you very much indeed. Pardon me. I think it's been great, 3 presentations. I've learned a lot. There is a question about from Damili Manana, and it's got really 2 parts to it. It's to Mapula, is where do we source the feed material to produce medical isotopes, and how large is the market demand for this product? So over to you, Mapula.
Thanks, Prof. I missed the first question.
The question was, where do we get the source feed material to produce medical isotopes? And how large is the market demand for this molecules of life-saving importance?
The material, for example, in the case of molybdenum-99, okay, maybe just also to clarify, molybdenum-99 and iodine-131 are extracted from the same target plates. So the raw material is the low enriched uranium target plates. The target plates are actually an alloy of uranium and aluminium. The uranium is sourced from overseas. There's maybe just 1 or 2 companies that can do low enriched uranium at this stage. Then in terms of ytterbium-176, which is the raw material to produce lutetium-177, also that is sourced from overseas. So yeah, the manufacturers of the raw materials are overseas. There is none in the continent, if I put it that way.
And how big is the marketplace? How big is the world market? I mean, before you answer the question, I think it's important to emphasize that this is one of the few industries where South Africa at one level has like 20% of the world market. And that's, I think, something we underestimate the importance of. But how big is the overall market for the radiopharmaceutical business?
Radiopharmaceuticals are used every single day. As I said, there is at least 8 to 10 million diagnostic procedures using technetium-99. So it is a multi-million rand business.
I'm going to help you there, because I'm going to change hats and become a bit of a presenter, because I happen to, let me see if I can find the right presentation. I was in a meeting that was discussed a couple of days ago, and I will find it shortly. So to answer that question, the overall market, this is going to be deep inside some presentation. Pardon me for being a bit it shows you the fact that I have too much in my in tray. There we are, that's it in there. It's in the billions of dollars. I'm just going to quickly find it, but I had a, if you take because the other thing is that to answer the question is that the production of the isotope is a portion of the overall market. It isn't the only commercial activity. But I'm about to get there. Market. Pardon me for being slow. I hadn't expected this question. How big is the market?
David, if I may, I can tell you that the global market of radiopharmaceutical has been projected in 2026 to be at about $7.5 billion.
Okay, that's kind of numbers. I've got a number I think it's bigger. I think I had $20 billion, but maybe a wider activity. So yes, it's growing at about 8% a year. It's a very I couldn't find it. Okay, but it's a very large market. So the answer to the question is, and I'll tell you now from a Nexa point of view, it's by far the biggest income after the government grant for other things we do in that market, and it's the one that is. I don't see another question. I'm going to ask a question, if I may, of Professor Vangu and Professor Avery, which is a bit radical. Our industry has been perpetually under the situation of there is no such thing as a safe dose, zero, the so-called linear no threshold hypothesis, which constrains general nuclear activities in the sense that you assume that everything is, all nuclear is dangerous. Any comments on the validity of the linear no threshold? I'm chucking that out at both Willie and
I think I will leave it to Stefan and the medical physics to say it, but generally, as you know, we have that principle that is very well known. It's called ALARA, as low as reasonably achievable. So we try the best to minimize and following the principle of ALARA, that is distance, shielding, and timing. These are the three prescripts of the ALARA, so that we can minimize. But you're totally right, David. There is nothing like zero. And if there was something like that, the world will be a happier place. But I can ask Stephen to put a further comment.
Yeah, I agree with following the ALARA principle, but also with the linear threshold model. I think these models, we use those in order to determine, well, what is the safest way to deliver radiation. Because I think that, you know, when people are treated for a certain amount of radiation for a certain amount of time, I guess these numbers are, you know, just don't come from anywhere. I guess that, you know, they come from the fact that we look at what is called a therapeutic window, and that therapeutic window tells us that, you know, at this dose you get the maximum return. Again, I mentioned in my talk that the two main factors of radiation therapy is to destroy the tumor and spare the normal tissue. And so using these models, we use that to determine what is the dose that's needed to get that maximum return. And so I think that, you know, they're still working on models and still developing, you know, and looking at them. But I think that is the basis of why we do different fractionation schemes, is based on these linear models.
No, I raise the issue because it's very much a radiation medical issue, because the problem we have and I'm seeing now from the engineering side of the nuclear power industry, is that if you want to get down to, as you get down by lower and lower numbers, the cost of doing so becomes exponentially higher. And it's interesting to say that the base of linear threshold was a 1960s assumption of simplicity. It wasn't based on observations. Anyway, I'm going to suggest that I see no more questions. I think that it's been an absolutely fascinating hour and a half for me. I certainly have learned a lot about this, and I think that we underestimate the importance of radiomedicine, whatever the right phraseology is. I'm sure someone will accuse me of getting it wrong, but radiopharmaceutical and beam type medicine. As we get to more esoteric things to solve it, when we're solving cholera and smallpox, clearly there's other things that we do, but now we're down to things we can't solve with medicine very easily. So that's a way of phrasing it. So unless there's any other questions, I'm going to suggest we call this to a halt. We let Professor Avery get to breakfast, which is about right now. You're still 5:30 in the morning, so we're going back to bed if you have any sense.
Well, so coffee would be good.
I would offer you a coffee, but I think it wouldn't get down the wires so easily. So I'm going to suggest that we call a halt to this, and if everyone's happy, my only call to all the attendees is thank you for attending. And I think that please visit the SAIEE website, where we have a section on upcoming webinars, and I think they're interesting, and I think we should be thinking. Thank you, everyone. Thank you all, and Santi. And I think we can now go back to our normal lives.
Thank you.
And with that,
Thank
I
you.
will cheers. Thank you.
Right.
Cheers.
Goodbye.
Right, see if I can find the close. Right, here's the close button here somewhere. Where's my button? I'm going to end the webinar. Thank you, everyone. Enjoy yourselves. Have a good day.
Thank you. Bye. Bye.